Today's webinar is a part of NCEE's Clinical Judgment webinar series titled Developing Student Clinical Judgment in Laboratory, Hospital, Clinical, and Field Phases, presented by Dennis Edgerly, Dr. Bill Young, and Bryan Ericson. I'm going to pass it over now to our presenters. Thank you all so much for being here with us today to share your knowledge and experience with us, and we look forward to the presentation.
Thank you very much, Rio. Just want to welcome everybody. Thank you guys for all being here. Dennis, Dr. Young, and myself are happy to be here and are part of the team that's doing the clinical judgment for paramedic and AEMT educator rollout across the nation. And just looking forward to kicking it off. So I'm going to go ahead and turn it over to Dennis. And Dennis is going to take it away and start off talking about clinical judgment in the laboratory setting.
Awesome. Thank you, Bryan. Good morning, everybody, or afternoon, I guess, depending on where all y'all are in the country. Kind of to back up in preference, hopefully everyone attending has had the opportunity to go through some of these other webinars or attend one of the sessions, the live sessions face-to-face. And the next one, I think, Bryan's at the EMS conference, Educators Conference, coming up next month, I think.
Correct. It will be at the EMS Conference Symposium in Pittsburgh this year as well.
Awesome. So yeah, so if you're unfamiliar, just to kind of backtrack a little bit, the National Registry of EMTs is in the process of changing their exam. The skills exam is gone, and the written exam has been modified to focus on clinical judgment. And we'll look at some schematics here that they're talking about. But we want to take that concept and focus today a little bit on how we as educators can help facilitate this learning process in various places in the program. So Bryan, could you click forward for me? Nice job. All right, so the EMS lab, I think, is where we as educators have an awesome opportunity to help students with this clinical judgment processes. We have isolated skill events. We have scenario simulation events that we can run students through. And I think sometimes we can get really just focused on just doing the skill, doing the event. And we're missing like a huge opportunity. Bryan, can you go next for me, please?
Sorry, computer.
I know buttons are hard.
All right. Here we go.
There we go. Awesome. So many of us learned this way, and many of us have taught this way. And many of our programs, like American Heart Association, PHTLS, AMLS, we still use algorithmic charts like this. Our protocols are written in algorithmic charts like this. When we're looking at the clinical judgment piece and helping students learn how to think clinically and to separate clinical, we talk about critical thinking. Critical thinking is a component of clinical judgment. So it supports the clinical judgment piece. So they're not the same things. One actually supports the other. And part of what we have to do is, and in the workshops, we talk a lot about metacognition, the process about helping students think about thinking and how to put things together. And when we're doing that, these flow sheets don't work for us. The National Registry sheet that's in the center that used to be used for testing, and many times we use that for teaching, was arguably injurious to students because it taught us step-by-step process. There's the little checkbox things at the bottom, and there's this hidden curriculum piece that suggests that this must be done in order. It must be done in sequence. When in reality, we know that it doesn't have to be done in order, and it doesn't have to be done in sequence, but still that was taught. The two algorithms on the outside, those are very definitively if-then type process. It doesn't talk about prediction. It doesn't talk about critical thinking. It doesn't talk about differential diagnoses, things. And many times when we look at algorithms, specifically through American Heart Association, we talk about the H's and the T's. And the H's and T's are great, but typically the H's and T's are something we mention at the end as our parting thoughts when our evaluator says, is there anything else you want to do? And you're like, oh yeah, I want to check the H's and T's. And they're like, great. And they give us a checkbox and they walk us out of the room. When in actuality, to help this clinical judgment kind of piece, the H's and T's actually need to happen first. That should be the first thing we should consider. And then our treatment from then follows that H and T process. So sheets like these sheets like these will not work. They won't work. So when we're teaching students an isolated skill, an isolated event, sure, let's talk about step 1, step 2, step 3, step 4. But we've learned early on that having a student repeat a skill, an isolated skill, over and over and over, we can actually have them repeat the skill to the point of crippling them where they can't employ that skill in any dynamic situation or call or event that takes place. Bryan, would you go forward for me, please? Thank you. And so we know that skills and labs have these two basically phases. We have the formative phase and we have the summative phase. The summative phase is where we're going to evaluate this process. And so at the end of our programs, we can run students through these critical thinking, clinical judgment events, which now, especially at the paramedic program level and the AEMT program level now, since we're moving forward with potential accreditation, and I think in EMT programs, there's no reason we can't do this in EMT programs, we now have the obligation as program directors to make sure that we're evaluating our students because they're not going to a national registry psychomotor exam anymore. So our programs have to put together dynamic summative assessments to make sure that our students are ready to go. The education piece happens on the formative side, how we help students put this thing together and how we help them critically think or clinically think for good clinical judgment. So Bryan, would you flip forward to our little wheels of fortune here? If you've not seen this, this is part of a document put out a couple of years ago, and it's posted on, I think, NCEE's website. I'm not sure if it's on registry's website. It's been sent out by emails to anyone that has participated. It's I'm sure if you do not have access to this entire document, if you were to send NCEE an email or any one of us an email, we're happy to forward this document to you. But this is the basis of which this new testing process takes place. And so just to discuss this a little bit to make sure we're all on the same page, we can see that clinical judgment is thematic all the way across the top. That's the goal. And it talks about the sequence of a call from the dispatch to responding to being on scene to after the scene. You can also see that leadership and communication runs all the way through this thought process, and everything rests on patient cues, environmental cues, provider factors. So that creates the infrastructure for what's taking place. And then if you look at each one of these little wheels, you can see each one of the clinical thinking points. And so if you look at the en route, it talks about recognizing cues. It talks about analyzing the cues. It talks about defining a hypothesis, which, ladies and gentlemen, I am open to say that defining a hypothesis is creating a differential diagnosis. Once we create a differential diagnosis, we have to help our students figure out how do I differentiate that? How do I know it's this versus this? How do I know it's this versus this? Which then requires me to take an action. And once I take an action, I then need to evaluate that action and then go back and recognize the clues of the action again. And it just loops forward. We educators have an awesome opportunity to build this entire thought process in the lab, in the safety of the lab. There's a lot of discussion about simulation and simulation clinical rotations and simulation ambulance stuff. And it doesn't supplant actual time, but it can definitively supplement what students are going to do in the clinical setting and in the hospital setting if we guide it correct. And so what we need to do is we need to coach these students through this process. So whether your lab is a simulated clinical rotation, whether your lab is a simulated ambulance run, we can help students through this process. So we create an event, and I've said for many, many years, a huge component of a successful simulation event is it has to be well crafted. It has to be intentionally designed. What are my goals? What are my objectives? What do I want to do? We just can't walk in and go, hey, Hank, would you just run a cool call that you ran last night and present it to our students? That doesn't work like we want it to. And then what we do is we coach the students through the process. So we get them into the event and we can ask them questions. What are you thinking? What do you see? How's the patient presenting? What do you see about their medication? So we have them actually be intentional about what they're seeing and what they're evaluating, which creates the obligation of us to make sure that whatever event we're creating is intentionally created. We then ask them to analyze that. So they have these medications. Why would they have these medications? What condition could they possibly have with these medications? Which then can lead me to, okay, based on these medications, based on how the patient's presenting, based on their initial findings, what do you think this is? And then we should help the students come up with a series of things. And we need to be specific. We shouldn't have them come up with, oh, I think it could be a cardiac issue or a neuro issue. Like what? Like what? I think it's a myocardial infarction. I think it's left ventricular heart failure, chronic secondary hypertension. We have to help them be specific. And then we have to help them say, okay, you're thinking it could be this. and it could be this. How do I differentiate those? How do I know it's this versus this? What other tests do I want to do? What other assessment do I want to do? How do I want to evaluate the process of this versus this? And then we have to have the student take an action. Once the student takes an action, we have to make sure that our scenario or simulation that we've created responds appropriately. We want them to respond appropriately. And by appropriately, we don't need to accelerate time. We don't need to artificially create things. We need to make sure that our simulated event responds appropriately. And then we can go back to the student and kind of go, what happened? What happened? Did they get better? Did they get worse? Did they not improve? Is there a new symptom that took place? And then we start it over again. So let's recognize the cues. Why do you think that took place? And it becomes this guided process, this coached process. This picture talks about pre-hospital, on-scene, and post-hospital, which is great for running simulated calls, but this can be broken down in any isolated event to say, we're just going to focus on this today. We're just going to focus on this today. For any of you online, and I'm looking at the names online, and I know many of you have been involved with the registry with the creation and building of some of these test questions. That's what these test questions are going to require students to do. They're going to ask them the pre-scene phase, what do you think this could be? Now you're on scene, what do you think this could be and what could you do? How do you differentiate this from this? The recognition of home medications is going to be crucial in these processes. And then now we're transporting, well, how do you explain what you see? Bryan, can you flip to the next one for me, pretty please? Awesome, thanks. And so when we look at this, these are just kind of some things we need to remember. This process has to be taught. It has to be taught. We can't just assume that students know what to do. We can't just assume that students know the questions to ask. We can't assume that the students know next steps. And then it has to be practiced. It has to be rehearsed. It has to be an intentional process. Has to be an intentional process. We should question our students. Why do you think it's this? Why did you do that? Why did you not do this? Were you considering this? Because that questioning process helps them think about how they're thinking. And thinking about how they're thinking actually helps them put together this process and deliver it. And then I get a whole list of stuff we just need to not use anymore. That polysyllabic word, I hate IVO2 monitor transport. No, if you're going to do an IV, tell me why. How much fluid are you going to give? What kind of solution do you want? Do you want ringers? Do you want saline? What do you want? If you're going to monitor what? Monitor what? Cardiac monitor, 12-lead monitor. If you're going to do a 12-lead, why do you want a 12-lead? And then typically when I'll ask, especially my new paramedic students, I'll say, why do you want a 12-lead? They could come back and go, well, it could be a cardiac issue. Like what? What do you, and it's like, well, it could be an electrolyte issue. Okay, like which one? And if you're worried about potassium, how did potassium get altered? It doesn't just happen. And so this question process, and any of these memory aids, they're awesome to get us started, but they don't work in the clinical judgment phase. I can pretty much guarantee there's not one question at the paramedic level on the National Registry test that says, tell me what DCAP BTLS means. I can pretty much tell you that does not happen. And so if that's the focus of how we're teaching, we're going to cripple our students when they actually go to take that test. So yes, use that lab time to be magical in what you do. Dr. Young?
Thank you, Dennis. That was great. I was sitting here thinking, man, I wish I'd gone through Dennis's paramedic program back when that would have made it when I went through. So anyway, what I'm going to talk about is clinical judgment in the hospital setting. And in many situations that we're looking at here, you're going to be doing a lot of debriefing because either number one, you're not going to be in an educational facility where you will be or your preceptors will be paid by the school of being in the hospital. So you're going to have to gather information from the students as they're coming back. Next slide, please. So basically what we're looking at here is, where do we begin? I'm going to date myself back with this show, great show called Dragnet. And in Dragnet had Sergeant Joe Friday. And when I talk about Dragnet, I'm talking about the original show, not the movie with Dan Aykroyd in it. And one of the things that Joe Friday always went for were the facts, just the facts as far as what we're looking at. And one of the things that I stress to my students is that they need to begin to think like detectives. And in essence, what they're trying to do is that they're trying to come up with enough evidence to convict this person of being guilty of this diagnosis. Now, I know that's a big stretch from law enforcement to EMS, but it does seem to work in the fact that, as Dennis said a while ago, you're coming up with your differential diagnosis, and you got to understand why you're coming up with those. And then you've got to narrow it down to the most probable cause as far as what's going in there. And the only way we can do that is by getting that information out of our patient. And in the hospital is a great way and a great place to do that. Next slide, please. So in this, I love this statement in here that's from the NIH. It says, good clinical judgment is required to select the most relevant research evidence. The best clinical judgment, though, is reasoning across time about the particular patient through changes in the patient's concerns and conditions, and or the clinician's understanding are also required. And in essence, what we're looking at here is we have two variables. We have the patient and we have the clinician. The patient is the person that we're taking care of, and the clinician is going to be your student. One or both of those can have variabilities in it that help them to lead into this clinical judgment. One of the things that we have to be able to do within the hospital is to understand when a patient presents this way, what is the most likely reason that they're doing that. And so this is one of the areas within the hospital and within your different clinical facilities that you're able to begin to really pull in this data again as you debrief the students. And one of the things that Dennis said that is so critically important when we're working with these with the particular students is to make sure that we're able to dig deeper rather than just a mnemonic, and to find out exactly what it is that they understand or don't understand. Both of those are equally valid. The last thing we want students to do are just simply to vomit out a bunch of mnemonics because it's going to check off a box. But when you've got a student that comes back and you say, let me tell you about this patient that I had, that's an ideal time to now be able to dig down and to go really deep into that. Next slide, please. So I've got a presentation here that is based off of a real patient that a student came in, and the patient was brought to the ED by EMS for altered mental status. Patient is a 72-year-old female with a baseline orientation of person in place. The son called 911 today after checking on his mother and finding her sleeping in the bathtub. Per the son, I tried to get her out of the bathtub, but she didn't recognize me. She felt pretty hot too, like she has a fever. She kept saying, go away, I don't know you. The son reports that she normally answers the phone, but when she didn't answer today, he went to check on her and found her in her bathtub acting strangely. Now, in this particular situation, we're still able to hit all three of the areas that Dennis presented for us a little bit, because this now, even though this is coming from the emergency department, now you're able to begin to query and ask your student. Okay, so now imagine that instead of this being told to you at the hospital, this was your dispatch information, that you got it there. Now, what would be some of the things that you would begin to think about and to dig into as far as your potential diagnosis? There are some things in here that are critically important, okay? Age. The fact that there is an altered mental status, the fact that there is an elevated temperature that's going in there, and in particular, the fact that the mom doesn't know who her son is, all comes into play here. And now, is this potentially a diabetic emergency? Well, maybe not, because she's running a fever. Well, okay, now is it sepsis? Well, I don't know. Is it one of those situations where maybe was she in a tub full of hot water? Or did the water start out hot and now the water's cold, and maybe we're dealing with a potential transition over into hypothermia? So you have multiple different directions that you're able to go with as far as this initial presentation and coming in and dealing with what it is. Next slide, please. So again, the patient is currently mumbling to herself nonsensical words, doesn't follow commands, and doesn't answer to her name. Facial expressions are symmetrical, and pupils are equal, round, and reactive to light. So maybe it's not going to be a stroke, but let's dig a little bit deeper. The patient doesn't follow commands for eye accommodation to be accurately assessed. Patient lung sounds are clear bilaterally. Chest rises and falls are even, and breathing is labored, even though respirations are 28 breaths a minute. Again, now we're digging deeper into this particular area. One of the things that I would encourage you to do is to have specific different types of questions that would apply to pretty much all of your patients. And again, once you're looking at this, and this would be a learning event also for us as the instructors, because again, unless we were actually there with the student going through this particular call, these are going to be a lot of, as far as our part, it's going to be some speculation based off of the best evidence that's being presented. And as a result of that, this would be a really good bonding moment to help the student see how you as the instructor want to learn more about what's happening with this particular patient as well. Next slide, please. Patient is currently incontinent, malodorous urine saturating clothing down to the patient's socks and shoes. Skin is hot and dry, tending trigger noted, as well as flaky skin. Mucous membranes are dry and tacky. So now are we looking at an issue here of sepsis leading into potentially dehydration that's coming in. The other thing that we're looking at is, again, with this malodorous urine, this really strong urine smell, is there a potential that this patient could be involved in some type of acute renal failure? And so we can take our students down that route as well to begin to see that patients don't come neatly compartmentalized in, well, they're just going to be a cardiac. And in this situation, we're dealing with cardiac. We're dealing with a neurological issue. We're dealing potentially with a renal issue. We're dealing with most likely an endocrine issue in the fact that if she is indeed septic, now what is her blood sugar? And we don't really have a history on her, but these are things that we can begin to help our students to see that they can go as deep as they want to throughout this whole process. Next slide. So the question here is, now what we're going to do is we're going to come up with the most likely diagnosis for our patient. Now, it's difficult to begin to develop a treatment plan, and we'll talk about treatment plans in just a minute, based on multiple diagnoses. But again, you have to have a primary and then a secondary that's going on through here. The most important question that you can always ask your student is why? And I love that question because I've asked that question at multiple different levels over my entire life. And this is just a really, really good question, because now it's kind of like an onion that we're peeling the layers back and we think, okay, I got this, I understand this. And then you say, well, why does this happen? You know, again, we were talking about a minute ago as far as if it's an electrolyte abnormality, and it's an abnormality of potassium versus calcium, why would that be? And what are the things that you're seeing that would help to bring that to light? So the why question is my favorite question to ask, because it allows you to now dig down deeper until you get to the point of where the student doesn't have a clue. And now you can begin to either, number one, help the student to learn, direct them to resources where they can learn, or you can learn together as you're moving through. Next slide. So we don't do much as far as care plans in EMS, but as students, we probably should. And basically what we're looking at here is the development of an idea of, this is what's wrong with our patient. This is how we're going to take care of our patient. And this is what we would expect to see as we're moving from point A to point B. one of the things I'm really excited about is that at the NCEE Symposium, I'm going to be doing a presentation called "Choose Your Own Adventure." It kind of goes back to the stories that we've read, and it's really quite easy. It takes a little bit of organization work, but it's quite easy to develop these so that if your student, using PowerPoints, if your student chooses A, now you can take them down this route, or B, you can take them down this route. But you always provide a route for them to get back to the right path. If we just simply take them down the wrong path on this plan of care, and we never give them a chance to correct themselves or to come back, the only thing that we begin to develop is discouragement, and learning really does not take place very well in that result. Next slide, please.
What? Hold on. You got to have the mouse on the right monitor, apparently. Sorry.
Yeah, go ahead and go to the next slide there. I think I've got a slide.
Yep. Sorry.
Again, when we're talking about this whole process of what we're developing, it really does sound like an awful lot of work, but realistically, this is done in about an hour. And the good thing about this is it's not an hour wasted. It's not an hour that is simply going to be busy work. This comes back to that whole concept of metacognition, of where we're thinking about what we did, we're thinking about how it affected the patient, and we're thinking about what happened after what we did in regards to the patient. And so this is one of those things that if we do this correctly, and again, this can be an individual exercise, or this can be a group exercise coming back from your hospitals. And the thing that I like to illustrate this with is that now students begin to recognize groups and classifications of patients and how they present. The example I like to give is that if you're sitting in a class and you've never really seen a patient with heart failure, okay, and so now I'm trying to memorize. Okay, I got oh yeah, so patient short of breath, yeah, tripod, yeah, I'll remember that. Pulmonary edema, okay, I got to remember what that sounds like. Maybe doing a little bit as far as, particularly if it's emphysema, maybe they're muscle wasting and they're very, very thin. Okay, got to remember that. Versus the person who has seen this and experienced it multiple times, and you have taken them into that area of really digging down. They go, oh, well, that was Mrs. Jones. We transported her last week. I know exactly what that looks like. And you can see the time frame that comes in very quickly. Next slide. So again, as we're looking at this, teach your students to be a detective, okay? Think about the future. Look forward. They say that the best chess players are those that can think 6 to 8 moves ahead. Do the exact same thing. If I do this, what's going to happen? Rank your actions from the most important to the least. But the bottom line here is always care for the patient. Model that so that your student will do the exact same thing. So, Bryan, I think you are up now, sir.
Awesome. Well, thank you, gentlemen. Yeah, I'm going to take over and talk about a little bit about the actual field setting and kind of what happens as our students transition from the laboratory in the hospital clinical, and then they actually go on into the field setting. And so, in the field setting, what is that purpose? I mean, when you really think about it. So, in the lab, right, we've always kind of really focused hard on establishment of the basic skills, demonstrate the students are competent. And then we put those students from the lab, we put them into the hospital clinical site where they actually start to see live patients and start to put it together. But it's really in that field experience, right? When we're putting them out in a 911 ambulance where they're actually out going to start and do the job. And they're actually, what I like to say, they take it from the head to the hands, right? They're actually now having to put into practice this piece, this really what I call a critical piece of what's going on in the setting. So when you think about the purpose of our field experience, why do we put students in field, in clinical? Obviously, it's allowing the students to start adapting and developing and kind of fine-tuning all of the things necessary to be competent paramedics, right? Our competent AEMTs or even competent EMTs. The whole goal of the field experience is to equip them so that when we're done with them, we wrap them all up in a nice big course completion certificate package. We send out a competent entry-level provider that's trained to be able to function in the environment that they're going to go to work in. So, they're going to develop their communication skills here, right? They learn how to talk to a patient. They learn how to talk to other crew members. They learn how to talk to their partner. I think one of our bigger challenges we see with a lot of our medic students here is the ability to delegate, right? They now have to actually delegate. And they're asking, for example, they might be asking that crusty fire captain on scene to, hey, could you please hold this? Or could you carry this for me? Or, I need you to get an IV. I need you to do this. I need you to do that. And so these are the skills they're now all putting together, and they're developing that whole kind of critical thinking process in piece. Now, it hopefully would make sense that when we launch our students out into the clinical area, into the field area, that we've equipped them with the right toolkit, right? So that's kind of a critical part of making sure your field experience is going to be successful for the students, is that they are properly equipped and ready to now go and start putting things into action. I think about a lot of times, maybe you guys had this preceptor, and in some ways I might have been this preceptor, but that preceptor where you show up and they look at you and say, here's the keys and you're running the show today. They kind of kick you off into the deep end and say, I'll keep you from killing anybody, right? And first, for a lot of us, that was kind of how we learned, right? They just dropped you into a scenario and you kind of fumbled through it. May not be the best way to help reinforce some of those critical thinking judgment skills, because the student doesn't even know how to model that behavior just yet. So early on in the procedure and the process of field, probably not a great idea, but later on in the process of the field setting, by all means, it's simply that they should be running the show and doing the things and being properly equipped. Now, when you think about clinical and you think about the field and you think about the class and the lab and all the different kind of components that go into a sound educational process, it's really, really important to stress that your field experience and your clinical experience is critical to the development of competent providers. I think all of us could remember back to the wonderful days of COVIDia, right? You remember COVID just a few years ago and all the crazy hoops and hurdles we all had to go through. And you remember that, we all switched to a very heavy simulation base, because we couldn't get clinical sites. All of our clinical sites just went away like that. We had no hospitals to put students. In some places, I know that didn't even have ambulances to put students. And so our state administrators and the COA and the NR, they all basically said, you know what, we can simulate things to get through this rough patch. I know quite a few places where they saw significant dips in pass rates. Students that were finishing the program were going off and not being successful in the registry. And then they're scratching their heads like, we did everything the same way. No, we didn't. We took them out of clinical. We took them away from real patients and real thinking and real judgment. And it's actually been proven through different areas, different studies. In fact, I saw someone on here. I see Dr. Lancaster here with us today, and I know that he did his dissertation over this. And we know that competence and success on registry can be tied straight back to how much clinical and field experience our students had. Interestingly, when the registry did some reporting, it shows that states that have higher clinical requirements have better NRAMT pass rates. California, for example, has one of the best pass rates, and they require a 480-hour internship for their paramedic graduates in California. Some places require 240, and I've been to places in my visits as a site visitor where there are no hour requirements, and students are completing their clinicals in as short as 100 hours, 120 hours. And so that time that they're spending with those patients and their preceptors is critical, right? Now, what is the challenge? So the challenge we often have is managing this practicum, managing this internship process, because what are we essentially doing? We're basically taking our students and we're moving them away from us and we're placing them in the hands of our preceptors. The thing that needs to happen is you need to ensure that your program is competency-based, so that your goals, your outcomes are clearly defined, that the students are actually doing real clinical application, they're actually doing things. We give them a diverse patient contact exposures. You want to make sure your students are seeing the pediatrics, the geriatrics, the trauma, the medical, all the different types of potential presentations they could potentially see. And we want to make sure that those students are progressing from that entry level into a point at the end of their internship where they're fully team leading every call, right? You know, with the COA and the SMC and the old tracking documents, we all know we have to demonstrate how the students are getting to those competency levels. The challenge in the past for a lot of places, and I think we see this more, especially at the AEMT and at the EMT levels, is a lot of things were hours based, right? So you just did a 72-hour internship. You went out, you rode for 72 hours and you were done. And there's some EMT programs that still do that. I know you can, you know, I know of EMT programs here in Texas that there is no hour requirement. They just got to transport 3 patients. So they could literally transport 3 patients to a nursing home and they're done. They've met their requirements and they're done. They don't get any clinical exposure or anything. There needs to be balance to that. You know, if you don't have a real clear outcome in mind and clear goals and clear objectives for the students in this internship process, field process, they're not going to get what they need in order to then start applying things. We have found, I mean, I know Bill and I've talked about it, and I've talked like this with Dennis and others, that, you know, the more our students are putting their heads in their hands and taking care of patients, the less concerned they become about things like registry testing and passing exams, because they learned that as I'm a competent provider and I can actually do my job now, that I can go figure these things out. Now, big linchpin to all of us is our preceptors. And you guys probably have the same struggles we all do, right? Preceptors are, man, they are gems. I have to have really good, dedicated preceptors that are really buying into my secret sauce, right? Are they basically bottling up and selling what we're producing? Are they actually supporting us? You know, I think one of the worst things a preceptor does for us is like, well, I know what old Dr. Young told you in class, but that's just a bunch of bull doo-doo. Let me show you the right way to do it here on the back of my Bamberlands. And that just kind of almost wipes out everything your student learned, right? They learned that, okay, everything I'm doing in class doesn't have purpose, when in fact it does, right? We don't play a critical role. Now, our good preceptors are going to be consistent. They're good role models. They allow for progression from entry level to competence to full mastery at the end. They take full ownership and are fully invested. I don't know about y'all, but those preceptors are rare. They're hard to capture. You know, if you guys are struggling like we do in large EMS systems or even small systems, staffing changes and movement around. So sometimes it's hard to get that consistency. You know, when shifts are changing every day and the students are going in and seeing different preceptors, you know, you may have a student who's almost at that point of taking over a call, but because he didn't do it the way his new preceptor wants it done, he gets set back, right? So it's kind of hard sometimes. You know, the shift bid comes in the middle of their internship and they get a new preceptor. Not having clear guidelines is a cruel part. That's why COA is so critical about making sure you got preceptor training, so that your preceptors understand what they need to do to help your students be successful. Hopefully you're getting good attitudes. I know sometimes we do get preceptors that basically don't want a student, right? They don't want a student. They don't want to deal with a student. You know, they may not have the best attitude. They may not even do really good patient care. Your students would come in and talk to you about it. And then you can actually use that as a teaching opportunity, right? You can say, you know, this is the kind of care you don't want to be, right? Is that the medic you want to be? Do you want to treat your patients like that? Do you want to treat your coworkers like that? Is that how you want to be able to be seen and be interacting? And those are things that are definitely challenging. And of course, sometimes we see students want to go work with their old partners. You know, well, I was an EMT with paramedic Dennis. I'm going to go ride with Dennis because he's going to be my preceptor now. And that might not be the best shake. So we got to be globally kind of impacted, looking at where our students are going and who they're riding with and how we're doing that. Now, what I'm showing here is something that we use here at Tarrant County. And this is just one example. I can't take credit for the development of this. I participated, but I have to give credit to Jeff McDonald. Jeff is our former director here at TCC. He's now down at Galveston College, works with the COA. And, you know, we are having struggles with keeping track of our students and how they're progressing. So one of the things that we do in the practicum phase of the internship field process is the students are assigned to a faculty member as their primary mentor preceptor. And this faculty member then follows that student from start to finish through the practicum process, through their actual internship. And we call it practicum versus internship, just language depending where you're at. And essentially what it is, the students would then make a documentation on every call, and they would designate the call as a simple, a moderate, or a critical. And then they would write down a function assessment of observe, assist, and team lead. Over to the right, you'll notice some percentages where the preceptor would actually complete this. We only asked the preceptors to say how much prompting was required, and then what percentage of the call do you feel the student ran the call. And so you'll notice here the first one is that it required about around 4 prompts and was running about 80% of the call. So that would actually qualify as a team lead. Now, it's not a full team lead, but it is a team lead. They were leading them the bulk of the call. And then the next one down you can see was not a team lead because it was 6 prompts and then it was 40% of the call ran. And that is something we can use to then track every call. So the students would come in with this documentation. They call it the yellow book here at TCC. And we review this documentation. And we very clearly state to the student that the expectation is, as you get to the end of your internship and you've met all your objectives, that you should be 0-100 at every call. You need to go and you can actually track them and trend them. Now, this is super helpful because it allows us as faculty to be in tune with how the student is seeing patients and talking to patients. So for example, if they're seeing preceptor flip and they're getting different preceptors with different calls, it allows us to then engage those students on interesting calls, right? So for example, the pulmonary embolus call that comes in, or, you know, we had a patient, one I reviewed recently was a shaken baby, and the student just didn't understand why this baby was seizing. There was nothing going on. And then we found that it was shaken baby. It was kind of a way to go back and share some of those different things. Now, one of the challenges we often see in programs is, what is the definition of a critical, a moderate, or a simple call? And I've gotten a little bit of trouble on this in the past, and I don't want to make anybody upset, but guys, if you start an IV and you do a 12 lead and maybe give a little bit of albuterol, that's not necessarily a critical call, right? It may not be an advanced call. Now, I know that your billing department may look at that differently, right? If you do a 12 lead, you start an IV, we're going to bill that as an ALS call. That's a different thing. We're talking about thought processes here. So again, this is something that Jeff helped develop, and we kind of developed here and implemented here at TCC, and we're continuing to run with. This is just a designation of kind of how we set up a patient as either being critical, moderate, or simple. And this was stolen from some nursing references, but there's a lot of references to different areas we can go out there and get this. Now, basically, the patient's got an immediate life threat, right? Anything you had to do is an immediate life threat. You had to do something. Since this patient was dying and needed transportation to the hospital, that is a critical call, right? So your multi-system traumas, your gunshots, things like that. Critical, like CPR, can be a critical call. Now, is it a high-risk situation? Was the patient confused or disoriented? Is the patient in severe pain or distress? Then that might be more of a moderate call, right? So procedures and skills, all you did was transport. It's probably going to be a simple. If you did just one skill or one procedure, it's probably going to be a simple. If you did more than one skill or procedure, and yet there really wasn't any significant vital sign challenges or any major life threats, it still might be simple. But this is all a tool that you can use to help the students actually classify patients correctly. And what we find is, over time, the students they'll come in and they'll have, like, say, for example, a heroin overdose. They come in, it's a heroin overdose, initial presentation respirations were 2, pulse ox was 70, patient was, near death, and they came in, assessed the patient, discovered it was a heroin overdose, administered some Narcan. The patient's now breathing 12 times a minute with a good pulse oximetry, skin's warm and dry, and they transported them to the hospital, and they mark it as simple. Wait, why is this a simple call? Well, it was pretty easy, Mr. Erickson. We just kind of came in and, we recognized it was heroin, and we gave him some Narcan. We got him breathing, we got him to the hospital. I says, no, that's more of a moderate call. You had to do something that required that interaction. So when we do this, and these guidelines are provided to the student, and these guidelines are also provided to the preceptors, it helps them navigate that process of determining kind of what it is they're doing, what they're not doing. Now, overall, the key thing when you think about your field process, and the field process with a clinical judgment piece and allowing our students to be successful, is this is allowing them to think while working, right? This is allowing them to actually put it into play. I tell my preceptors, I tell my 5th semester students all the time, I said, guys, this is the only time you get to go out and be a paramedic, and you get to have someone standing behind you to keep you from killing the patient, right? So this is an opportunity for them to put it into practice. They should be prompting, they should be questioning, they should be working with that preceptor to help them understand what's going on and reflecting what's going on. There's a lot of brief non-interventional reflection going on, day-to-day call stuff going on, okay? This is also a really good opportunity to help reinforce not only thinking while on the call, but thinking after the call, also reflecting back on what's going on. If you've got for example, a system that I did a site visit recently, I was real jealous because the students were actually assigned to one preceptor for their entire internship process. And they had to come in and meet with the medical director at the halfway point and the medical director at the end point. And I was so jealous because I got to watch one of those midpoint meetings. And I was like, wow, this student was so engaged with that preceptor, and they were reflecting on where they come and where they're going, and what the end goal is going to be. And the medical director was interjecting. I was like, wow, this is kind of cool. But a lot of us don't have that luxury. We don't have the resources to do that. But this is an opportunity for those debriefing processes to take place that you may do with faculty on staff, right? You have them come in and talk to somebody, talk about those calls. Hopefully they're engaging with their own preceptors and doing this. Obviously, structured debrief is an important part. This is something we want to get the students practicing when you're thinking about the internship process is, what went well, what was ineffective, what do you want to do differently next time? What would you do different next time? And we do this with all of our internship meetings with our students. Is every call, we often flip it around on them and say, well, why'd you do this? Why'd you do that? Another process of this is we go in there and we review things like documentation. We'll go into whether it is your FISDAP, your MC, or your Platinum, whatever it is you're using, or paper. We make our students, for example, write SOAP notes. They have to write detailed SOAP notes, and then they get cleared to go to computer-based charting. We go back and we review that charting with them. Does their charting reflect accurately what's going on? But overall, we're kind of reinforcing through the whole process of this internship and practicum is you're taking the students, you're putting them in a position where they learn to become reflective. They learn to understand that they're assessing their patients, they're reacting to those patients, they're making those diagnoses we've discussed earlier, they're applying the fixes for those diagnoses, they're then reevaluating those fixes. Are things getting better? Are things getting worse? This all becomes part of that student's process. The documentation that we use, because part of our portfolio, we show how the students go from the beginning to the end, and we document and capture that data so that we can share it. Some other things you can look at doing if you want to expand out field internship clinicals is look at essays. You can have students write essays on patients. I traditionally don't have them write an essay unless they make me kind of like they do something silly like, we used to go to the hospital when I was with UT Southwestern and go to Parkland, which is like one of the busiest trauma centers in the country. And you'd ask a firefighter what's going on. They say, nothing. So, okay, cool, nothing. I'm going to go find a diagnosis. You're going to write me an essay. And I'll go find like a gallbladder patient or, something that was nothing. And they go write an essay on it. And they go, oh, wow, there's kind of more to it. This is something you can use sometimes. You want to get them to go deeper into presentations or a diagnosis. If you want to understand medications are coming across, those kinds of things. These are things that you can then kind of help build that repertoire for the student to build those things. Another option you have is rounding. You can take them out, round them in the emergency rooms, round them in the EDs, round them in the ICUs, allow them to get out there and see patients in different situations. This is kind of more of back on the Bill side of the clinical side. We don't do it as much in practicum, but it does allow them to go back and round. Some places will use physician shadows during their practicum internships, where the students will go shadow a physician for a 12-hour shift and actually just do the assessments and the diagnostics with the physician. So the physician's helping them fine-tune that patient assessment and judgment skills. But those things are all things that we can do to kind of help think. Overall, what I really want to stress for all of us is when you're thinking about your lab, when you're thinking about your hospital clinical, and you're thinking about your ambulance field time and your practicum, always be thinking about how that plays into what your students are learning to do, right? How are they putting it into play, right? We can't do things the way we used to do things. We no longer can do, shock, shock, shock. Everybody shock, little shock, big shock, big shock. I think I just named Dr. Young Twitch. I have those mnemonics still in my head, decap BTLS, looking for decap BTLS tick. Well, what is decap BTLS tick? I don't know. I'm looking for decap BTLS. It's a thing, right? We have to get these guys to test, learning and putting things into play correctly. One thing I do want to stress, and I think I've learned this over the last year, is we're looking at this rollout for the psychomotor exam. The psychomotor exam going away has a lot of people nervous and conscious. Obviously, the test is going to change, and we have this new test coming out. And I'll be honest, I'm not really changing that much. There's not a lot that I'm doing differently in my own classroom. The only thing that I'm doing differently is more computer-based testing for the students, right? Implementing the technologically enhanced items, implementing the drags and the drops, seeing the scenario and variations in Canvas, things like that. But the things that we do in the lab, the things that we do in the hospital, the things that we do in our internship really isn't changing. Fundamentally, the goal here is if you make your student a competent entry-level paramedic, a competent entry-level AEMT or EMT, that student should be able to go off and pass the test, because the test is measuring that very simple baseline knowledge necessary to enter our profession. So if you're preparing your students to enter the profession and be competent providers, hopefully you're going to see the results that we all anticipate, which are going to be good. Well, that kind of wraps things up for us today. I hope you guys found this time useful. If you have any questions or anything, by all means, please throw them up in the chat. And Dennis and Dr. Young and myself are going to hang out here for a little bit, and we'll be happy to answer any questions that come up in the chat. But again, thank you very much for taking some time out of your Tuesday, and hopefully we'll see everybody at Symposium. We will be offering the full live version of this 8-hour class where you would come in and learn how to do stuff, even write items and do things like that. And that's a pre-con at Symposium. So please sign up, come to Symposium, and that pre-con for this particular thing is free. It's a free pre-con. So come on to Pittsburgh. So thank you guys. Appreciate y'all. And Dr. Young, Dr. Dennis, Dennis, I made you a doctor. Sorry, I do that to me all the time. But you guys have any comments? I'll let you wrap it up.
Well, we've got a question here from Gavin. It says, what program are you using for field tracking, and how do you gather preceptor feedback and comments? So Dennis, do you want to weigh in on that for Gavin?
So one more time, what are we using for what?
What program are you using for field tracking, and how do you gather preceptor feedback and comments?
Got it. Yeah. So in our program, we keep piloting different versions of different tools. So yeah, I've used them all, and yes. So we use we're actually currently looking at Platinum. We might use that. As far as the more specific stuff, I actually have a paper copy that during field internship I send with students, and it gets evaluated quarterly. So our students do 480 hours, and then quarterly there is it's a multi-page document that I have the preceptors complete and fill out to submit back. So I can have the points in the top and everything else in the data tracking thing, but then I actually have a paper document that I try to use to get more detailed information from both student and preceptor. It's a double way kind of evaluation piece.
We use a combination of paper and computer as well. We've used FISDAP. We're moving over to MC to track the skills and the patient numbers, the contacts, the diagnosis, the demographics, et cetera. Because the preceptors rotate through a lot, it's hard for us to get in there and do the evaluation tool. So we do that with the individual assigned faculty. But we have a paper thing that's signed by the preceptor with a rating scale. We have the preceptors rate on that paper that gets added into the documentation by the primary instructor that follows them. And then all goes into that end process for portfolio.
Excellent. So I think that was the only question I'm seeing. Rio, did you have anything else that popped up?
No, I don't see any other questions.
All right.
All right. Thanks, everybody.
Thanks, everybody.
Y'all have a great day, and thank you so much for